Good afternoon. Thank you for the invitation to speak today. So I'm going to speak to you about the dietetics perspective from nutrition support in nursing homes, and specifically about the HSE nutrition support pack which we issued out to nursing homes in the past 2 weeks. So I'll be referring to that throughout the presentation, and it's available at www.hse/nutrition supports. My own background is that I lead the nutrition team for residential care sites in the Midlands. So we have 9 sites across 4 counties, 450 beds plus daycare and respite. And I suppose I have also had the unfortunate position of contracting COVID-19 myself, so I've recovered for that as well. So I just give you a little bit of my personal insight in relation to that as well. So I suppose the key message I'd like to get across to you today is that we need to act and treat without delay for malnutrition risk. There's only a small window of opportunity to act swiftly and appropriately to prevent someone's physical decline due to decreased nutritional intake exacerbated by illness, which is in this case COVID-19. And malnutrition independently can be life-threatening if poor nutritional intake or an inability to eat persists for several weeks. So why is nutrition support so important? Well, in the absence of COVID-19 infection, what we're trying to do is slow frailty progression, or on the flip side of that, to build resilience in our residents. We want to optimise their health and immunity and give them the best quality of life possible. To decrease the complications and morbidity associated with the disease. We know that COVID-19 infection increases malnutrition risk due to the side effects of the disease itself and the treatment options, and also the isolation and psychological factors associated with the isolation. And then in COVID recovery, if you don't have optimum nutrition, you won't have optimum rehabilitation. It is equally important as the other aspects of rehabilitation, as well as quality of life. So we have here the cocktail of factors that we do not want to see in terms of nutrition. We have increased nutritional requirements, decreased intake and absorption, we have inflammation, and we have immobility. And this leads to lean tissue and functional loss, poor outcomes, and increased frailty if not acted upon. Our normal day-to-day role within residential care facilities as dietitians in the HSE sites is very varied, as well as individual nutritional assessments for residents and care plan development. We lead nutrition steering groups and MDT teams, we liaise with catering, we write the policies and standards in line with the HICWA guidance and other best practice guidance. We oversee tube feeding, and we look after specialised diets, and we do mealtime observations, just among some of the work that we do. What I want to get across to you, I suppose, what I want to kind of say most importantly in this presentation is that if we have to identify the residents, we have to assess who needs further treatment and what treatment they need and what treatment is appropriate. So we just want to try and support you with some practical guidance around that. In the normal scheme of things, we would always be advocating for screening. Screening, it's only screening, it's not diagnosis or full nutritional assessment, but it allows you to target your resources and care where it's most likely to have effects. And we usually take the approach of stratifying people into low, medium and high risk. But in relation to COVID and the situation we've had over the past months and weeks, we have produced a more proactive guidance, I would say, where we treat any level of risk the same and apportion a high nutrition support intervention strategy in terms of high protein, high calorie diet and ONS to try and intervene on any negative side effects of poor nutritional outcomes. And this was developed by a multidisciplinary group. It was a 2-week turnaround, and we did receive a lot of feedback, but obviously these things can't always be perfect when you need to get something out quickly to people to help them. So in relation to nutrition screening, I've done a lot of work in this area in my past life for my PhD. There's 2 screening tools that basically are the most commonly used within residential care settings in Ireland in HSE facilities as per an audit that we did in 2018. A lot of you will be familiar with the MUST, which is basically a 3-step tool. It is very focused on physical measurements, so weight and height and BMI. So if these become difficult to do or unable to do due to infection control or in very, very high stressful times during maybe an outbreak in your setting. There's also an acute disease effect score, and at the moment that should only be applied when somebody has eaten nothing for 5 days or expected to be eating nothing for the next 5 days, but we are seeking clarification from the BAPN group in the UK as to whether that should be applied to people with severe COVID disease as well. In relation to the M&A screening tool, that's the one we use in our sites, it's not as dependent on physical measures, and it does allow for psychological stress, acute illness, cognitive status, dementia. It's an older person specific tool, and there's some new evidence that it might be a little bit more sensitive in COVID to pick up malnutrition risk. So I suppose my key message would be, do we need to increase the frequency? We definitely, if we can maintain these pathways and not abandon them during this time, but also if we can increase the frequency to make sure that we have that sensitivity to pick up the malnutrition risk. This paper reviewed the different screening tools in relation to malnutrition risk, and I suppose just the key point that I want to highlight was that all the patients with COVID-19 had a much higher risk of malnutrition than the standard population, and the patients who had malnutrition had significantly longer length of stay and increased disease severity than those not at risk. So early intervention was really recommended by the authors. So in the absence of formal screening, what we advised in our guidance was to be vigilant for two key areas: sudden changes in appetite and food intake and unplanned weight loss, and the importance of your staff on the wards who actually feed the patients, who perform personal care in observing these issues, and also onset of new GI symptoms, which we know can be a cofactor of COVID. A lot of us have worked very hard on our protected mealtimes and our mealtime experiences for residents over the last couple of years, and we can really see the impact of the infection control measures now on this mealtime experience for our residents, and I've just listed some of them here. How can we limit this? And it is a big challenge. We still need to monitor the food intakes and document, as that's our evidence for the interventions that we move forward with. But we do need to keep the mealtime calm and free from any distractions. Ensure that food is at the right temperature, even getting meals to individual rooms while they're still hot. A lot of our residents would have small fridges in their rooms or coolers that allow them to keep cool snacks and that, which is an advantage, and if that can possibly be done. In relation to regular fluids and high protein snacks, you need to increase the frequency of the drinks and snacks rounds, if anything. Myself, when I had COVID-19, I had extremely sore throat for the first 5 days, and even if you don't have dysphagia, soft foods might be better tolerated. And again, if you completely use your taste and smell, and again, I couldn't tell the difference. I could eat a raw onion and I couldn't tell the difference. If people with dementia or elderly people are experiencing this, all you have is presentation of the food, encouragement, and maybe hot and cold sensations to encourage their appetite. And fresh air before a meal can stimulate appetite, as we know. And the company with maybe a favourite staff member, I meant to say a familiar staff member, we know they don't have favourites, but that can help with encouragement as well. In relation to making the most of every bite, we've produced a number of resources in the pack that we sent out, a snack menu, and we also have a very detailed cookbook which we worked with UCC to produce a couple of years ago, and it has excellent high protein, high calorie recipes that can be adapted for the residential care setting, and they're all available on www.hse.ie/nutrition supports. And the issue of food fortification, if this can be done at catering level in the kitchen to save time at ward level, so adding your extra cream, butter to foods, the porridge, the main meals, it's really important. If you're going to be hydrating your residents, which of course would be on the fluid rounds, make sure that the fluids have some other calorie or protein value if you can. We mentioned before about not messing with tea, but everything else, if you can try and make sure that there's some calorie or protein value. So we've recommended whole milk, fortified milks, again, high protein milkshakes and soups in the morning and evening. That's working really well in our sites, and we're using recipes from the cookbook that I've mentioned already as well. Oral nutritional supplements can be really useful in this setting because they can provide very, very energy dense in small amounts protein and calories to patients. We are recommending high protein ONS at this time, and at least a minimum dosage of 2 supplements per day if tolerated by the residents and liked. You can divide them into smaller doses over the day. That can work really well. You can also combine them with foods, and I just have some ideas there on the slide in relation to how you can kind of maximize that time with assistance feeding if that is taking a lot of time with residents. In our experience, if you give them just after breakfast or late in the evening, it doesn't take away from the main food intake as much. If you need to use them as a sole source of nutrition, I think this came up as questions in the short term, you can do this, but you need support from a dietitian to do this safely, because a lot of supplements are not suitable for a sole source of nutrition, and 1 or 2 definitely won't meet requirements. You'd be talking about 5-6 bottles a day to meet residents' requirements. In relation to monitoring, a lot of people are asking about monitoring. We would want to continue this pathway for at least a month if the resident has been identified at risk of malnutrition, and then gradually decrease down after that. I think the importance here, if this strategy is not working of food fortification and diet and ONS, there needs to be an MTD discussion about this as soon as possible, and the advanced care plan is really, really important in this respect. There is a small number of residents who would benefit from the likes of advanced, maybe temporary NG feeding to get them over severe disease or in the initial phases of recovery, and that should be discussed early in the advanced care plan for each patient. So when I'm speaking about other considerations, think about IV hydration, bloods, use of ONS, but also discuss tube feeding in that care plan for the resident as you would in general terms. And good communication between the team is really important. In terms of end of life, we've spoken about comfort feeding a little bit there, but in relation to that the patients and family would understand about this time is where we're just focusing on providing a little enough and what the person wants, and assistance where can be required. And we have additional resources on our page as well in relation to the language and the explanation to families and carers around this. So I just want to mention quickly about enteral tube feeding. You may notice residents who contract COVID don't tolerate their enteral feed as well, or even on their current regimen they might start to lose weight because with the increased requirements associated with COVID. So you need to consult your dietitian in that respect, and if you do need to stop feeding, it needs to be reintroduced slowly. I don't have the time in the presentation to go through refeeding syndrome in detail, but I just want to highlight to you this issue because it's not something that commonly occurs in the nursing home setting, but it is something in these times that we felt it was important to flag, and there is a very good detailed guideline on erspen.ie that you can look at in this respect. In relation to vitamin D, there's been a lot of controversy on this lately, and again, I'm not going to have time to discuss this in detail, but I just want to mention these 3 key papers that have been published in the two in the Irish Medical Journal, and also the BMJ have done a review. And I suppose we have looked at all this and we've condensed it into a simple guideline for you. We feel it's safe to advise 20 micrograms of vitamin D as a daily supplement to frail residents who are not already on supplements, and we provided a table in the guidance just to show you that a lot of the ONS that you might be using might have vitamin D as well, and commonly used supplements. So just to make sure that you know when you're thinking about dosing what you're giving. So there's more information available from the National Dietitian Advisor Office, or if you have issues around reimbursement as well. So I'll just leave these slides up and acknowledgements and references. So thank you very much.
Thank you, Kathy. Yeah, so hi everyone, I'm Sarah. I'm a speech and language therapist here in Tala University Hospital. Over the past 2 months, I've been working on the COVID designated wards along with some colleagues. Specifically, I've been working on the age-related ward, which is how I've got involved in the presentation today. So I hope you find it useful, and thank you for the invite to present. So just to revise some common causes of oropharyngeal dysphagia. So dysphagia can be caused by a variety of causes. So one would be a neurological impairment, such as dementia, stroke, or progressive neurological conditions, such as Parkinson's, MND, or MS. You may have residents in your nursing home presenting with these conditions, and some of these may be at risk of dysphagia. Structural damage, such as trauma caused by intubation, so damage to the voice box, the larynx, or any head and neck malignancies. The effects of the toxicity of medication and the side effects of drugs. Presbyophagia, which is an aging swallow presentation, where some residents or patients may present with a psychogenic dysphagia subtype. So just taking it back to basics and reviewing signs and symptoms of dysphagia at a broader level. So you may be familiar with drooling, difficulty chewing, patients unable to clear residue from their mouth, coughing or choking while eating and drinking, a wet, gurgly voice while they're eating and drinking, patients presenting with increased shortness of breath as they're eating and drinking or post-meal time, a red face or eye watering, a history of repeated chest infections, weight loss, residents that are taking a long time to finish their meals, residents that may be complaining of difficulty with eating and drinking, or may be reluctant to eat certain levels of consistencies. So these are all signs and symptoms to recognise in your nursing home, and to be aware that these would necessitate speech and language therapy referral. So just in terms of the different client presentations that we've seen in the hospital in terms of COVID-19 specific patients, so if patients have been escalated to intensive care, so to ICU, They've often present with severe acute respiratory distress syndrome, ARDS, and these patients will have been intubated, ventilated, and some proned. And when they're extubated, our critical care SLT ANA would have seen them, and these patients may present with voice problems such as dysphonia, swallowing difficulties, commonly known as dysphagia, cognitive communication difficulties, or chronic upper airway and respiratory problems. So other risk factors for dysphagia in COVID patients that I've seen at a ward-based level and may be familiar to you from your nursing home residents would be reduced alertness or consciousness, delirium or increased confusion, a possible primary respiratory dysphagia subtype. So these are patients that may be short of breath due to COVID and have difficulty altering the swallow and dysphagia coordination. The effect of intubation or non-invasive ventilation, or else deconditioning or increased fatigue, potentially affecting the efficiency of the patient's swallow function. Signs and symptoms of dysphagia in COVID patients that we have seen at a ward-based level will be a loss of appetite secondary to a loss of taste or a smell, coughing on food or fluids due to a worsening respiratory status. So sometimes these COVID patients are coughing anyway due to the coronavirus itself, but just to differentiate that between patients who are coughing more when they're eating and drinking. Difficulty chewing due to fatigue, deconditioning and shortness of breath, or difficulty recognizing food or food boluses due to confusion and or delirium. So just at a broader level, consequences of untreated dysphagia would be from a social perspective, withdrawal from meal times, or pre-COVID maybe avoidance of social occasions that involve eating and drinking. From an emotional perspective, embarrassment, frustration, confusion and anger, or even some residents from a medical perspective may be presenting with malnutrition, dehydration, weight loss, chest infections or an aspiration pneumonia, and worst case potentially death. So I know there has been some concerns around access to speech and language therapy during this global pandemic, and just a safe feeding routine that I thought might be helpful to kind of help map out if you have a patient with in your nursing home presenting with signs and symptoms of dysphagia. So the first thing that I would recommend you do is contact your usual SLT provider, be it HSC community or private, to refer and flag the resident to them. Request a telepractice or a telephone consult, so whatever is on offer in that service, for individualised advice where possible. And then in the meantime, revising steps to promote safe oral intake, which I'll go through in the following slides, to try and help promote safe oral intake at mealtime. And if you're not already linked in with an SLT service, I would recommend that you link in with your GP attached to your service, the local HSC community clinic in your area, or else the local SLT department in your nearby hospital for some advice and to help get some guidance around exploring other avenues. So just in terms of steps to promote safe oral intake, so if you have a patient with COVID who's presenting with signs and symptoms of dysphagia and you're awaiting SLT input, I highly recommend that you go through these kind of key factors to try and help increase the safety of their swallow. So first of all, if they have dentures, making sure that these are in place. If they're a little bit loose, seeing a Fixodent will help them secure them in place so that they're nice and tight. In terms of alertness, sometimes these patients with coronavirus may be very fatigued and drowsy, so don't offer a resident food and drink if they are too drowsy. It's safer just to skip that meal and come back to it when they're more alert. If you're feeding the residents, try to position yourself at eye level to help them maintain a neutral upright position. And if possible, if you could encourage the resident to sit out safely, try to do that so they're in an optimal upright position when they're eating and drinking. And as Sharon already said, distraction is a big thing. So in your unit, if you could try and turn off the TV or turn down the radio so that the patients and the residents can really concentrate on the food and drink. In terms of patients who may have been seen previous by SLT, if you just check the dysphagia care plan at their bedside matches with the meal that they've been given. And if it hasn't, bringing that back to the kitchen and getting an alternative meal at the correct consistency is really important. And just checking that the thickened fluids at the patient's bedside are thickened accordingly to the SLT recommendations that are at their bedside. Some other steps to consider in promoting safe oral intake would be portion size. So a lot of these patients with COVID are fatigued, they're deconditioned. So looking at kind of giving them small, little and often amounts would be something that we'd find has been really beneficial on a word-based level here, by trying to add sauce or chop up the food for them to see if that would help make it more efficient for them. In terms of independence, try to encourage the residents to eat and drink themselves if they can. But if they are struggling, try look at hand-over-hand assisted feeding instead of doing it all yourself, because they'll get some sensory recognition by having the bolus in their hand and bringing that up to their mouth, and that will help them as well recognise that they're about to start eating and drinking. Some of the patients that we've seen here have had reduced taste, and offering them kind of carbonated or fizzy drinks or foods of different tastes or textures or temperatures has helped, so that would be something that I recommend you try. Then also just to allow them adequate time to eat. So some of these patients may be taking longer given they are fatigued and deconditioned. So just making sure that you're allowing them as much time as they need to finish their meal. And then one thing that I think you can really do well in the nursing home is around oral care. So ensuring that the mouth is clean before they eat and drink and afterwards. And if they have any food and drink left in their mouth, encouraging them to take a drink or to just double swallow, to have another swallow is often very helpful for these patients. So you may be wondering whether you should pick in fluids or self-modify residents' diets while waiting SLT input. This is a contentious issue, and as per RC-SLT, the expert guidance is out there that it's not possible to predict which residents will benefit from changes in fluids using thickener, owing to the complexity of the pathophysiology of the swallow. So thickened fluids can cause more difficulty for some patients and residents. With thickened fluids, you need increased intrabolus pressure orally and at the level of the upper esophageal sphincter, so between the pharynx and the esophagus. Thicker consistencies may also increase the residue left in the throat. Higher rates of silent aspiration has been found in one study when patients aspirated thick fluids, whereas patients tended to cough when they aspirated thin fluids. So it's all very patient and diagnostic specific. And there's an increased risk of dehydration on thicker fluids as well. So modified fluids and diet should be only used with caution and following recommendation by speech and language therapists. So just in the interest of time, unfortunately I don't have time to go through these resources, but I was really keen to give some practical and some helpful resources that I feel would be of benefit in your nursing home to refer to. So this is by Lanchester Teaching Hospital. There's advice around swallowing and communication and mouth care at this link here. In terms of dysphagia resources, if you're using Nutrilis in your nursing home, they have lots of meal ideas. There's a Nutrilis Cure resource pack and recipe books and some thickening guidance that might be helpful to print off and use in your nursing home. Similarly, if you're using Fresenius Cowbell products, they have lots of resources on their intranet that I suggest you check out as well. In terms of IDSI, we've changed over in Ireland. The HSC has endorsed the changeover to the IDSI International Dysphagia Diet Standardisation Initiative labels. So instead of the old Irish national descriptors from 2009, we're using the new IDSI levels. And there's lots of webinars and posters available on the IDSI website that may be helpful if your nursing home needs training in this area. Not to forget communication. Cheeverstown in Dublin has made some lovely documents you can see here on the left that are aphasia friendly and will help open up discussions with your residents around PPE, social distancing, or if another resident that may be a friend of theirs have gotten COVID, and just helping to support that discussion in an aphasia friendly manner. There's also some communication boards that are specific to COVID, as you can see here on the right, that may be helpful to augment the communication of any residents who may have communication or cognitive difficulties. One question that came in was around language stimulation ideas. So I've listed these on the left that I feel might be feasible to include in your nursing home, and just a resource here of some language stimulation ideas that may be of benefit to incorporate into your nursing home setting. COVID-19 oral care, as I've mentioned, is really important. There's a really nice document here. It's only 2 pages around COVID-19 specific advice in terms of optimizing oral care and hygiene. There's also a COVID-19 voice resource that was published by some experts in the field in the UK. So if any of your patients are hoarse, this would be something that I suggest you refer to for extra guidance. And just to wrap up, I appreciate that there has been changes in service delivery across the country. These seem to be service specific and I guess out of my remit as an acute speech and language therapist, but I do recommend that you contact your local SLT, be it HSC or private. Our professional body, AIIHPC, has recognised that assessments that may prevent hospital admission and expedite discharge from acute services may be deemed a priority. So just get in touch with your local service and see what supports they can offer. Can they offer a telephone consult, a telepractice video consult for initial assessment, for reviews, or just maybe general advice around comfort risk feeding versus modifying diets and food recommendations. Just to wrap up, that recommendations are highly individualized, so make sure to follow your SLT guidance. So just some resources, and thank you for listening.